Our next chapter involves the diseases of the adrenal glands, and we're going to start off with hyperfunctioning of the adrenal glands, and we're going to be talking about Cushing's syndrome. The Cushing's syndrome is a very interesting disease, and we could all remember the typical presentation that we see with Cushing's syndrome, the acne, the buffalo hump, the moon faces, the purple striae, the truncal obesity, and then they develop hyperglycemia. This is important, finding hyperglycemia because the corticosteroids are counter-regulatory hormones, so about 20% of these patients have frank diabetes, and they also develop hypertension in a good percent of the population because the corticosteroids, again, cortisol has mineralocorticoid action. It's not potent mineralocorticoid action, but it has some, and these patients develop hypertension. Patients that have Cushing's syndrome for a long time, they develop osteoporosis. Right, this is typical of patients either taking steroids or they develop Cushing's syndrome, that they develop osteoporosis, especially when this occurs over a period of time. These typical features, right here, these are all the typical features of Cushing's syndrome, and if you take away the iatrogenic cushingoid features that people get if we give them steroids, for example, people that you treat for lupus, with steroids for a long time, or people that have steroid-dependent asthma and been taking steroids for a long time. These, if you take away those, this typical presentation only occurs with this thing called Cushing's disease, which is the pituitary form of Cushing's syndrome. So that's the typical disease that causes the typical presentation of Cushing's syndrome, and that was the disease that Harvey Cushing described almost 100 years ago at Johns Hopkins when he presented a case of a pituitary adenoma that had a buffalo hump, moon faces, the striae, all the typical features of Cushing's syndrome, and this is referred to as Cushing's disease, the pituitary form. The pituitary form is the one that's long-standing. It occurs for a long time. That's why you develop the typical features. Some of the other Cushing syndrome, and we're going to talk about it just in a little bit, don't have the typical features. You don't get the buffalo hump because they're short-lived syndrome. So, for example, a patient having a lung cancer who develops lung cancer, oat cell cancer, and they secrete ACTH, a paraneoplastic syndrome occurs, cushingoid features that these patients develop a Cushing syndrome. I shouldn't say cushingoid features. They develop a Cushing syndrome. They don't have the typical presentation of the acne, the buffalo hump, the moon faces. The reason is because these people lose weight, they have cancer, they seem wasted, they don't have the typical features. So the typical features occurs only with iatrogenic forms of Cushing's syndrome or Cushing's disease, the pituitary form of Cushing's syndrome. Now, so I want to give you a little bit of an overview and talk about these different types because they're important for the boards. Now, the most important one, and is that we see clinically is iatrogenic or exogenous Cushing syndrome, and you usually know about this because the patient says, yeah, I've been taking 20 milligrams of prednisone for steroid induced asthma for the last 15 years or so. So that's usually known. It's not something that it's hidden in the history. And this by far is the most common form that we see of Cushing's, the iatrogenic, the exogenous form when the patient's taking oral prednisone for years and so forth. The endogenous form, which is the endogenous form of Cushing's syndrome, right here, the most common form is Cushing's disease, right here, Cushing's disease. That's the most common form of endogenous Cushing syndrome, and really when we talk about Cushing syndrome, we're really referring only to the endogenous form because the exogenous referred to as cushingoid syndrome. So Cushing syndrome, the endogenous form, Cushing's disease, The pituitary disease is the most common form of this syndrome, and then after this it's adrenal neoplasia, and then after this it's lung cancer, the other forms. But I want you to remember kind of as a stepwise way to remember the etiology, because when you work up the patient, that's the way you have to remember the etiology and the differential diagnosis. So when you start up high, the first cause is pituitary adenoma in the pituitary. Then you go into the lung, where you have lung cancer producing ACTH. This is small cell cancer. And then further down into the adrenals, where you have some kind of adrenal neoplasia or adrenal hyperplasia or something like that. But now you have cortisol production. Remember, with the pituitary form and the lung form, you have ACTH production. With the adrenal form, you have more of a cortisol production, and the ACTH in these patients is suppressed. It's downregulated because of the high production of cortisol. So Cushing's disease, the most common form, and lung cancer, a paraneoplastic syndrome, are ACTH dependent. They produce ACTH to basically upregulate the adrenals, to produce cortisol, to develop Cushingoid syndrome, and then adrenal neoplasia or adrenal hyperplasia of any form, any adrenal lesion. In these cases, you have cortisol production by the adrenal, and now the ACTH production is downregulated and inhibited. So let's say you have a patient that you're considering has the clinical suspicion of Cushing's syndrome, some form. You've excluded the iatrogenic form, so you think this patient has some form of endogenous Cushing syndrome. So they have some kind of osteoporosis, or they have the truncal obesity, or the purple striae, and so forth. And then you decide that you have to answer the question, does this patient have Cushing syndrome? And the first test to do is this easy screening test, and this is called the overnight dexamethasone suppression test. Now this is easy because you could give this patient the dexamethasone. The dexamethasone is a potent cortisol derivative, right? And you give it to them overnight. They take it in the middle of the night, and then they come in the morning and you measure cortisol in the morning. Now, think about that. If you give them dexamethasone, a potent steroid derivative, overnight, a patient that's normal, you should suppress the ACTH cortisol axis in the morning. So a normal patient, once you give them dexamethasone overnight, you should measure cortisol in the morning. If they don't have any Cushing syndrome, their cortisol level should be suppressed. So here it is. Look at this. You gave this patient overnight dexamethasone, right? And if it's normal, right, which is suppressed right here, suppressed, then you stop. This patient doesn't have any Cushing's, because you proved that you could suppress this cortisol. And you can't do that with any forms of Cushing. So the overnight dexamethasone is a good early test to do to say to exclude Cushing's. It's only used to exclude, because if this test is abnormal right here, if this test is abnormal at this place right here, now look at this. Although it's a good test to rule out Cushing's, an abnormal test can occur in obese people, it could occur in depressed people, it can occur in anxious people, so it has a lot of false positives. So it's used to rule out the disease, but if it's positive, then we have to go to one step further, and we have to do the gold standard test, which is the 24-hour free cortisol. This is the gold standard test. Whatever this says, this is it. Now some books will tell you to go to this test right away, the 24-hour free cortisol. And yes, the answer is, if they give us one test to do, then forget about the overnight dexamethasone suppression test and just go to the 24-hour free cortisol, because that's the gold standard test. Why some people don't do it right away and they use it as a second test is because it's labor intensive. This patient has to collect 24 hours of free cortisol. You have to give them a special jug. They have to send it back. They have to send it to a specific lab. It costs a couple $100 to run this test. So it's a more expensive test, but yes, it's the single best test to do to diagnose or exclude Cushing's syndrome, all forms of it. Because the overnight dexamethasone has a lot of false positives, this is the gold standard test, but I wanted you to know the overnight dexamethasone suppression test because it's still in some of the questions that we use. If they give you both of these tests, then you're going to go straight to the 24-hour free cortisol. That's the bottom line, because that's the gold standard test. Whatever this test says, that's the bottom line. If it says that the 24-hour urine-free cortisol is normal, no Cushing's. You could stop right there. This patient may look like Cushing's, but they don't have Cushing's. If it's an abnormal test, you have Cushing's syndrome. Cushing's syndrome. Now the question is, where is it? Where could it be? And you know where it could be. It could be in the pituitary, in the lung, or the adrenals. You have to localize it now. So to recap this part of the workup, there's only 2 tests that you could do to answer the question, does this patient have Cushing's? The overnight dexamethasone, which is a good screening test sometimes, a good first test, but the gold standard test is the 24-hour free cortisol. Some people do only 1 test and they go straight to the gold standard test. So it's okay to do that as long as you know both of these tests and how to use them. Now, we're right here. We got a patient that looks like they had Cushing's, and we did a 24-hour free cortisol, and they have an elevated 24-hour free cortisol. So they got Cushing's syndrome, right? So what do we do now? Well, we know some differences. We know some differences. One difference between these 3 different diseases is that some of them have elevated ACTH levels, right? That's the lung cancer and the pituitary lesion. And the adrenal has low ACTH levels. And then the other big difference is that the pituitary adenoma, also called Cushing's disease, is a more benign disease. It's more suppressible. People say it occurs for 10 to 12 years before the diagnosis is made because it's such a slow disease. It's not like the other diseases like the lung cancer and the adrenal lesions where these are more aggressive diseases. So it's a more benign disease, and if you increase the amount of cortisol that you give this patient, if you increase the amount of dexamethasone, I should say, which is a cortisol derivative, you could suppress the pituitary lesion because it's more benign. It's less aggressive, more benign, and you could suppress it. And that's the other difference. So those are the 2 differences, and look what we do. We base the rest of our workup in localizing the lesions in these differences. So look at this. The first thing we do is we give now the high-dose dexamethasone suppression test. Now I increase the amount of dexamethasone from 1 milligram to 8 milligrams because I say to myself, okay, I know one of these types of lesions I could suppress if I increase the dose because it's a more benign disease. The other ones are aggressive and nothing is going to happen. So look at this. I give the guy the overnight dexamethasone, the high dose dexamethasone suppression test, and if I suppress it, forget about the 50% control here, just say suppress it, suppress cortisol in the morning, then the answer is it could only be one thing, pituitary adenoma. Pituitary adenoma, this patient has Cushing's disease because that's the only one that's suppressible with the high-dose dexamethasone suppression test. And what do I do right here is I localize it. What's the best way to localize the pituitary is do an MRI of the pituitary right here to localize it, and then I send this patient to the surgeon, and it's a very, very treatable disease. So everybody's happy in the end with this disease. On the other side of the coin, though, what if I give the overnight dexamethasone suppression test and now there's no response? So now I say to myself, okay, I got one of 2 things. I either got lung cancer, it says here ACTH producing tumor, right there, lung cancer, that's the most common one, or adrenal neoplasia. Do you know any difference between the two? Yes. I know that one has a high ACTH level and the other one is low. So I'll measure ACTH here. If it's low, I have adrenal neoplasia. And what do I do now? I get an MRI or a CAT scan of the adrenals to look at that. You don't have to know all this stuff here. The urinary 17 KS and DHCA and stuff like that, you don't have to know that. All you have to know is that if the ACTH level is low here, we have adrenal neoplasia, and do an imaging study of the adrenals with an abdominal CAT scan or an MRI to localize the lesion and find it there. If the ACTH level is high, right here now, then you only got one thing, and that's lung cancer. And then we do a CAT scan of the chest to localize the lung cancer. Unfortunately, most of the times this is unresectable, untreatable disease. Now, they may also ask one more question about Cushing's syndrome on the boards, and that is, they may ask you, are these two patients clinically different? And the answer is yes, because these patients here, right here, with lung cancer have elevated ACTH levels, they have hyperpigmentation. In fact, they have a lot of hyperpigmentation because lung cancer secretes a lot of ACTH. So these patients develop hyperpigmentation that's significant. You could see it clinically, versus these people with adrenal neoplasia here, where they don't have any hyperpigmentation. Now, people with Cushing's disease also have hyperpigmentation right here, but it's less significant. It's usually more profound with the lung cancer because the lung cancer is very aggressive and produces high amounts of ACTH. And remember, it's the ACTH that causes the hyperpigmentation because it's co-secreted with melanocyte stimulating hormone. In fact, they look exactly the same. There's only a couple amino acids difference, and that's what causes the hyperpigmentation. It's a factor of ACTH. Now, so I'm going to recap here and just tell you, please know this. They could ask us one question and they'll go down here and asking us different tests, and they're positive or negative, and then they tell you in the end, well, what is this patient likely, what type of Cushing syndrome does he or she likely to have? So we have to know the two tests that tell us the diagnosis of Cushing right here, the overnight dexamethasone suppression test, and the 24-hour free cortisol. The 24-hour free cortisol is the gold standard. And then once we have an answer from that we do have Cushing's, then we really do only two tests to localize the disease. And that's the overnight high-dose dexamethasone suppression test and the ACTH, nothing else. So really two tests to diagnose the disease, and then two tests to localize the disease and tell us which of the three syndromes we have. So we have to know about that. So a little bit further down, we want to talk about the diseases of the aldosterone axis, and I want to tell you a little bit about just what the effects of aldosterone is, and then talk to you about hyperaldosteronism, which is a very important scenario on the boards. So the effects of aldosterone, remember, we have antidiuretic hormone to reabsorb all the free water, right? That's the main water retaining hormone. And aldosterone is the main mineral corticoid that also keeps intravascular volume stable. So if you lose your mineral corticoids, you have intravascular volume collapse. You develop hypotension, salt-losing nephropathy, and so forth, and you develop severe hypotension and dehydration. So the effects of aldosterone really have to do with stabilizing your intravascular volume. Now, what your aldosterone does is it reabsorbs sodium from the kidney, from the tubules, right, to maintain this intravascular volume. So to maintain this intravascular volume, you reabsorb sodium, but at the same time, what happens is you lose hydrogen ions and potassium. So here, I want you to remember the effects of aldosterone are you reabsorb sodium, so you increase sodium in the body, right here, and at the same time you get rid of, because you're reabsorbing sodium, you get rid of potassium, so you develop hypokalemia and hydrogen ions, and this is why these patients also develop metabolic alkalosis. So low potassium, you lose hydrogen ions, metabolic alkalosis. So intravascular volume is the stabilization of intravascular volume by sodium reabsorption is what aldosterone does. At the same time, you waste potassium and you develop hypokalemia, and you waste hydrogen ions and you develop a metabolic alkalosis. So let's look at these two entities. When we talk about aldosteronism, we really talk about two entities: primary aldosteronism and secondary aldosteronism. Now I'm going to go to and talk about secondary aldosteronism first, because this is the most important one clinically. This is the one that we see every day in clinical practice. Now look at this. The initiating event here is right here. This is the initiating event here in a circle. This patient, for some reason or another, has intravascular volume depletion, right? So think about that. What could cause intravascular volume depletion? Well, dehydration, any forms of dehydration. You vomit a lot, right? Any forms of dehydration again. Overdiuresis, we gave the patient too much diuretics, or any of the edematous states. Remember, like congestive heart failure, right? Like low oncotic pressure, nephrotic syndrome. These people, overall, their volume overloaded, but their intravascular volume is depleted because they either have high hydrostatic pressure or low oncotic pressure. So here, this initiating event, any forms of dehydration, overdiuresis, or the edematous states, that's what they're talking about. So what happens is your intravascular volume in this case goes down, and now look at this. This goes back to your renin apparatus here, and your renin reads decreased intravascular volume, and this revs up your renin here, and what this does is your renin now secretes aldosterone. It revs up your aldosterone, and what your aldosterone does here is reabsorb sodium, right, to kind of minimize this depletion in intravascular volume. It tries to stabilize this loss of intravascular volume here. That's the important thing. So it does that, and sometimes the intravascular volume loss is so big that it can't, but it still tries to minimize it as much as it can. Now look at this. Once you start secreting aldosterone here, what do you lose? You're losing hydrogen ions, so these patients develop a metabolic alkalosis, and you're losing potassium, so you develop a hypokalemia. And so they may ask us on the boards, well, how do we know if a patient that we're treating with diuretics, we're over-diuresing this patient? So we're treating a patient with diuretics for heart failure or hypertension. And they ask us, well, how do you know you're not over-diuresing this patient? And the answer is, if I find metabolic alkalosis in this patient that I'm using diuretics in and significant hypokalemia, I know I'm over-diuresing this patient, because look what I'm doing. I'm decreasing their intravascular volume and causing this whole thing, right, to get activated here, the renin-aldosterone apparatus. So they tell you in that patient that you're treating for heart failure, what do you do with the furosemide? You don't stop it, you decrease it a little bit. You go from 60 milligrams to 40 milligrams to prevent this secondary aldosteronism. Please be careful, because patients using diuretics for weight loss sometimes develop secondary aldosteronism and severe hypokalemia, and they come to physician with hypokalemia, metabolic alkalosis, and it's usually a young patient, and people can't figure out what's going on. So think about it. Think about that. If a patient comes in and they have metabolic alkalosis and for no reason at all, and hypokalemia, think about secondary aldosteronism, either because they're surreptitiously using diuretics, or sometimes they have bulimia and they induce vomiting, so that causes the depletion of intravascular volume, and it generates the renin-aldosterone secretion and hypokalemia and metabolic alkalosis. So people with unexplained hypokalemia, metabolic alkalosis, think of secondary aldosteronism. Either they're using diuretics to lose weight, or they're inducing vomiting, like in bulimia and so forth. So please think about that. Go here to this part right here, to this figure, and now you'll notice something a little bit different. That the initiating event here now is down here, right here, aldosterone production. This is the initiating event, right? And look at this. This patient has a tumor in the adrenals, and what this tumor produces is aldosterone, autonomous secretion of aldosterone. Now look, the sodium now is reabsorbed. So now you get intravascular volume expansion. What this does is it causes hypertension. So primary aldosteronism is a form of secondary hypertension. We see it in young people with difficult to control hypertension, especially diastolic hypertension. And the reason is because aldosterone reabsorbs sodium and increases intravascular volume. Now at the same time, these patients will develop hypokalemia and metabolic alkalosis. So they may ask you on the boards, what is the cause of a young patient's hypertension when they have hypokalemia and metabolic alkalosis? And the answer is primary aldosteronism. The reason is because, look at this, you're using aldosterone here to reabsorb sodium, and you're wasting potassium and hydrogen ions. They may also ask you, well, how can you tell the difference between primary and secondary aldosteronism? And the answer is they both have elevated aldosterone levels. The difference is right here in the renin. If the patient has primary aldosteronism, right, and your intravascular volume increases here, your renin is inhibited, right? Your renin is suppressed. Versus here, where your renin is elevated, because remember, it's the elevated renin that increases the aldosterone in secondary aldosteronism. That's why in secondary aldosteronism, it's also referred to as renin-dependent aldosteronism, because it's really dependent on the renin that is secreted at high levels because of the depletion in intravascular volume. Versus primary aldosteronism, look at the renin here, it's low. This is also referred to as renin-independent aldosteronism. Independent because there's a tumor or mass here that secretes aldosterone autonomously, so the feedback back to renin causes inhibition of renin. So please, all the essence of primary and secondary aldosteronism is right here in this slide. If you understand what we talked about here in this slide, you know every question that they could ask us here. Primary aldosteronism presents as a form of hypertension. Secondary aldosteronism, these people have depleted intravascular volume. That's why they get secondary aldosteronism. So we're talking about different patients, but the concept, right, is the same. It's about aldosterone. I want to talk a little bit about the differences between one more difference here. Patients with primary aldosteronism, they don't have pedal edema here. It's very important. Despite reabsorbing a lot of sodium, despite increasing intravascular volume, it's very important that you understand here that these patients right here, do not have pedal edema. So that's one of the big differences between primary aldosteronism and patients with secondary aldosteronism. Remember I said some of these patients have edematous states, so patients with secondary aldosteronism sometimes have edema. And then the second big difference, I just told you just before, is that patients with primary aldosteronism have hypertension. These patients with secondary actually have hypotension, low blood pressures. So everything else is the same. Everything else is the same. All the other lab findings are about the same, the hypokalemia, the metabolic alkalosis. So the only difference between these two are the edema that exists only in secondary aldosteronism, the hypertension that exists only with primary aldosteronism, and I'll tell you a third one, the renin, which is decreased in primary aldosteronism and always elevated in secondary aldosteronism. So keep that in mind and know this slide because it basically summarizes all the stuff that we just talked about. I'm going to be talking next about this group of diseases called congenital adrenal hyperplasia. In the adults, the only one that we really see, and the one I want you to know, this is not pediatric cases where you could see various forms, but the most common one in adults by far is 21 hydroxylase deficiency, and that's the one I want you to know about. Now, these are syndromes where basically you have relative adrenal insufficiency. That's the way I want you to remember that. Even though the term says adrenal hyperplasia, the adrenals are hyperplastic, but these are relative syndromes of adrenal insufficiency, and I'm going to show you that. I'm going to show you an overview. I'm going to go to the next slide and then come back to this one, where basically it shows you the three pathways where you go from cholesterol, and then you go using these enzymes in the adrenals. You go all the way to your left here in the middle corticoids, aldosterone, right? You produce aldosterone when you go through this pathway, and then in the middle pathway you go to cortisol. So this is your cortisol production via these enzymes, and then all the way to the right here, all the way to the right here, you go to the sex hormones, right? The testosterone, the estradiol, and so forth. So what is congenital adrenal hyperplasia and especially 21 hydroxylase deficiency? Well, these patients have relative deficiencies in enzymatic pathways here, right here and right here, right? So this area here is blocked off. Depending on how much enzyme you have, you either produce zero aldosterone, zero cortisol, or some of it. Most people have some production of these enzymes, 21 hydroxylase deficiency, and you produce some aldosterone and you produce some cortisol, right? But what happens is when you have a relatively blocked area here, right, because you don't have a sufficient enzymes, what happens is everything here backs up and your progesterone increases. So one of the ways to diagnose 21 hydroxylase deficiency is they ask us, well, what's elevated, right? Well, the progesterone and the progesterone derivatives are elevated right here, right? Progesterone, 17-hydroxypregnenolone, and stuff like that. Well, the other thing that happens is also this. If everything backs up here, and these enzymes during this pathway here are not infected, well, everything then gets shunted towards this pathway, towards the androstenedione, testosterone, estradiol, and all this pathway. Basically, you get shunting of production during this pathway here, and inhibition and blockage during these two pathways right here. So everything gets shunted to the right towards estradiol, testosterone. There's some production of aldosterone, cortisol, but everything is backed up there. But why do the adrenals get hyperplastic? And the answer is because you don't produce enough cortisol. These patients don't produce enough cortisol, so the feedback back to ACTH from cortisol is a positive feedback, and you rev up your ACTH, and what happens to these adrenals, they get very big, they get very hyperplastic because they're trying to compensate, trying to make more and more cortisol and compensate and make more aldosterone to keep up the needs of the body. So a relative insufficiency and a blockage here, production of elevated levels of progesterone and progesterone derivatives, shunting of the pathway to the right, testosterone and estradiol, and hyperplastic adrenals. That is the essence of these diseases. So let's go back here and let me give you an overview of the 21 hydroxylase deficiency, because that's the one that they're going to ask us. If they do ask one single question, they're going to ask about 21 hydroxylase deficiency. It's a relative decrease in aldosterone, along with a relative decrease in cortisol. There's adrenal androgen excess. Remember the pathway to the right, everything gets shunted there. The enzymatic defects block everything there, so you have elevation of progesterone and progesterone derivatives. That's the way we diagnose it sometimes. And I told you that 95% of the cases we see of congenital adrenal hyperplasia by far are due to 21-hydroxylase deficiency. So even if you don't know anything about these diseases, if you pick 21-hydroxylase deficiency as a cause of congenital adrenal hyperplasia, it's the right cause about 95% of the time. Now here's the deal. We got to know a couple of things, the difference between what happens in this disease to males and females. In females, right from the get-go, right from the start, the neonate has ambiguous genitalia. So the physicians, the pediatric physicians, the gynecologists, they pick this up right away, right? And they make the diagnosis. So females are diagnosed early before they leave and they go home from the hospital because of the ambiguous genitalia. The males look normal. They look phenotypically normal, and they develop later hypotension because of mineralocorticoid deficiency. So they present later with hypotension, salt-losing nephropathy, and they're brought back into the hospital just within about a week or two after they go home, where everything looked fine. The diagnosis is, you should consider it in any patient that develops hypotension and mineralocorticoid deficiency. Even in adult patients, these patients, they don't get diagnosed early because they have some production of aldosterone and cortisol, and then they get themselves into trouble if they develop some kind of sepsis syndrome, or they get dehydrated from other causes, and now they can't compensate. So you got to think about it in those patients, and one of the first things you check is you check for an elevated progesterone. The treatment is the treatment of any cause. It's the same cause, the same treatment as adrenal insufficiency. So we give hydrocortisone and fludrocortisone at the same time, because this patient is not only missing the cortisol derivatives, but also the mineralocorticoid derivatives, so we have to compensate that with fludrocortisone. So hydrocortisone, HC, right here, plus fludrocortisone for the mineralocorticoids. So please know that just a little bit, not more than we just talked about 21-hydroxylase deficiency and congenital adrenal hyperplasia. Don't memorize the chart, the figure here. Just know the concept that we just talked about, the three pathways, and why you get hyperplasia and why you get relative aldosterone and cortisol deficiency, and everything gets shunted to the right here of the sex hormone pathway. A little bit further down, now I want to talk about real adrenal insufficiency, Addison's disease, and we have a primary type. A primary type involves the primary organ, right, the adrenal, and the most common cause of this is autoimmune or tuberculosis. Worldwide, the most common cause is tuberculosis, but because tuberculosis is not endemic in this country, most of the cases that we see are usually autoimmune in this country. So the most common cause in the United States of primary adrenal insufficiency is autoimmune. This is like an antibody-mediated disease. And then we have some other causes of primary adrenal insufficiency that usually happen in patients with HIV, like CMV adrenalitis, MAI adrenalitis, HIV adrenalitis. So it's common to see it in patients with end-stage HIV. There's also a syndrome where there's an acute adrenal insufficiency. This is due to disseminated meningococcal infection, usually Neisseria infection, and it's usually called the Waterhouse-Friderichsen syndrome. This is not the typical type that I'm talking about here. When I talk about adrenal insufficiency, I usually mean the chronic form. I don't mean acute, where the patient has meningitis and develops hypotension and they bleed into their adrenals. This is the Waterhouse-Friderichsen syndrome. I don't mean that. We're talking about more of chronic forms. So that's an acute form, and it's very rare, and it happens with Neisseria meningitis. The secondary form of adrenal insufficiency usually occurs with pituitary lesions. The tertiary form is extremely rare. So the secondary lesions usually are either pituitary apoplexy or Sheehan syndrome or some kind of tumor in the pituitary or some kind of adenoma that erodes into the pituitary and destroys the pituitary. So secondary causes are uncommon, but they occasionally happen. The symptoms are the classic hypotension. If a patient has primary adrenal insufficiency, not secondary, these patients develop hyperpigmentation. Now this is a clinical pearl here, because you could use the hyperpigmentation to distinguish between primary adrenal insufficiency and secondary adrenal insufficiency. So this is a very important clinical fact. Now a little bit more on the adrenal insufficiency. These patients have a couple of characteristic labs that I want you to remember. They develop hyperkalemia. If you have your aldosterone apparatus involved, you develop hyperkalemia because you're missing aldosterone, so you don't secrete potassium, and you hold on to it, and you develop hyperkalemia. Patients with adrenal insufficiency commonly present with hypoglycemia. And then the third one I want you to remember is eosinophilia. About 25, maybe 30% of the cases of adrenal insufficiency have eosinophilia. We don't know why, but you have to think about, in the differential diagnosis of eosinophilia, don't think about only allergic diseases, parasitic diseases, don't think only about asthma. Think about adrenal gland dysfunction, especially if the patient has some vague complaints like muscle pain, low-grade fever, fatigue, hypotension. Think about hypotension. Think about, if you see eosinophilia and hypotension, definitely think about adrenal insufficiency. The diagnosis is made through the ACTH stimulation test. Now remember, the ACTH stimulation test definitely diagnoses, it will diagnose primary adrenal insufficiency. So you give the ACTH and you measure cortisol, hydrocortisone and cortisol at 0 hours, at 2 hours, and at 4 hours. So basically, you're looking at the cortisol level, and what you want to see after you do the ACTH stimulation test, you want to see it go up, right? Double. At least go up, 30–40%, but usually it doubles. And then you've excluded adrenal insufficiency. So you measure 0, right? The level is 0 hours as soon as you give the ACTH, and then at 2 hours you see it go up, and then at 4 hours it's gone even higher up. And then now you could exclude adrenal insufficiency. Now if you see a flat line and no increase in cortisol production, then this patient has adrenal insufficiency. This is called the ACTH stimulation test. Now here's the thing that they've tested on the boards. Why does the ACTH stimulation test also diagnose secondary adrenal insufficiency? And the answer is it does, because in chronic adrenal insufficiency, chronic secondary adrenal insufficiency, remember ACTH has trophic activity for the adrenal glands. So if you're missing your ACTH, your adrenals atrophy. So if a patient has Sheehan syndrome and they had it for months or years, well, the adrenals are atrophied. So if I give this patient ACTH, they're not going to respond right away. They're going to take some time to start, working normally. So basically, as long as the secondary cause is chronic, then the ACTH stimulation test will diagnose both secondary and primary adrenal insufficiency. So please remember that. Now somebody has asked me this, and of course it makes sense. If a patient has acute adrenal insufficiency secondary, like pituitary apoplexy, then the ACTH stim test would be normal, because the adrenals don't have time to basically atrophy. So this is very, very important that you understand that concept. So the diagnosis is made through the ACTH stimulation test, and once the patient is diagnosed with adrenal insufficiency, then the treatment is simple. We give the patient what they're missing, hydrocortisone, and if the patient has is their mineralocorticoid apparatus. The aldosterone is also involved. We also give fludrocortisone at the same time. If the mineralocorticoid apparatus is not affected, then we just treat with hydrocortisone. And the way that we know that is if you're missing mineralocorticoids, then you develop the hyperkalemia, then you develop a severe hypotension. So some patients won't need fludrocortisone, only hydrocortisone. But if we see electrolyte imbalances, if we see severe hypertension, that patient needs hydrocortisone plus fludrocortisone, because that patient likely has both of the mineralocorticoid and the cortisone apparatus involved. One last thing I'm going to say here is please make sure you understand that when we give back hydrocortisone and fludrocortisone to patients with adrenal insufficiency, we're giving them maintenance doses, everyday maintenance doses. What your adrenal does is, if you get infected, it increases the amount of cortisol production, right? So if a patient with adrenal insufficiency whom you are treating with hydrocortisone develops some kind of febrile syndrome, some kind of infection, or they're going to surgery, you're taking them to surgery, you have to increase the amount of hydrocortisone that you're giving them, sometimes fourfold, to be able to compensate. That's what the adrenal would do if it had normal function. So just to give you an idea, we give doses like 15 or 20 milligrams of hydrocortisone a day, and if a patient is going to surgery and has adrenal insufficiency, we increase that to 100 milligrams twice a day. So you could see 5 times the amount of hydrocortisone if they're getting, you know, some kind of significant surgery, abdominal surgery or something like that. So please be aware of that in case they ask us, what do we do with the hydrocortisone? If this guy is going to surgery or has some kind of infection, we increase it, you know, at least a couple times over the baseline that we give the patient. I want to end the chapter with of the adrenal glands with talking about pheochromocytoma. Now, pheochromocytoma is, they like to ask us questions about pheochromocytoma because it has a couple of testable things on it, and also because it's a pretty common cause of secondary hypertension. So pheochromocytoma is a disease of the sympathetic nervous system. We have to remember the rules of 10% in pheochromocytoma. So 10% occur in children, 10% are bilateral, 10% are malignant, and 10% actually recur. So sometimes you have to follow this patient long term. The typical crisis that the patient has is one of hypertension, right? Labile hypertension, the blood pressure goes up, they get a headache, they get flushing, they get, you know, palpitations and so forth. That is the typical crises that patients with pheochromocytoma have. The problem is that not all of these patients have the typical crises. About 60% of these patients have stable hypertension. So why would you think about pheochromocytoma in somebody with stable hypertension? Well, number one, it's in a young patient. Number two, you notice that you need a lot of medication to stabilize this guy's blood pressure, like at least 3-4 medications. And number three, you notice some very interesting things in this patient. For example, they develop orthostatic hypotension. No other patient with hypertension develops that. Only patients with pheochromocytoma because they're dehydrated. So orthostatic hypotension in somebody with hypertension, think about pheochromocytoma. The second thing that you notice is some of these patients have a paradoxical response. So you give them a beta blocker or a central acting medication, and their blood pressure, instead of going down, goes up. And this probably has to do because you're leaving a lot of the alpha receptors unopposed. So now you're getting a response where the hypertension is exaggerated. Some of these patients may develop hyperglycemia. The diagnosis of pheochromocytoma right now is mainly done by the urine test. The best test to do to diagnose, a single test to diagnose pheochromocytoma, are the urine-free catecholamines. If they don't give us that, there's a couple of other good tests in the urine. The metanephrines and the VMAs in the urine are also good. A new test has come around that now people check in the serum. And the free catecholamines in the serum now are going to be looked at over the next couple of years as a way to diagnose pheochromocytoma. But I want you to know that the best test here is the urine-free catecholamines. Now let me tell you, a lot of people have asked me about this. What do you do if you suspect pheo and all the urine tests are negative? And the answer is, you don't do anything because this patient doesn't have pheochromocytoma. If the urine tests are negative, please don't go any further. Don't do any imaging studies because you're going to get yourself into trouble. This patient doesn't have pheochromocytoma. You may want to repeat the urine study. So sometimes the patients do them wrong, or they don't do them at the right time. They don't do them at the time of crises. And you tell them, okay, repeat the urine test, collect 24-hour urine again. They give them a special jug, and they wait until they get, the hypertension or the palpitations and the headache, and they start collecting urine, and that's the way to go. But if the urine studies are repeatedly negative, I'm telling you, this patient does not have pheochromocytoma. You cannot diagnose pheochromocytoma unless you have positive hormonal studies in the urine. Please remember that. After you've diagnosed it through the urine studies, then you localize it with an MRI or a CAT scan of the adrenals. If you don't find it in the adrenals, remember 10% are extra adrenal, so go outside the adrenals because it's somewhere in the abdomen, maybe the chest. We had a guy that had a pheochromocytoma at the base of the skull. So look for it in other places. Once you localize it, there's only one treatment. The definitive treatment is surgery. Is there any exceptions? No. Everybody has to get surgery because a pheochromocytoma, if you leave it, it will cause strokes, it will cause damage to the heart. It's not a benign disease. So these patients get into trouble. They stroke out, they get other manifestations. So the definitive treatment is surgery, and you always have to think about definitive treatment with pheochromocytoma, especially because a lot of these patients are young. What do you do though before the surgery? Because if you take this person straight to surgery with no treatment, and the surgeons start to manipulate the adrenals, right, to take out the pheochromocytoma, this patient will develop a hypertensive crisis and crash on the operating table. So what you have to do before is you have to give adequate alpha blockers to suppress the blood pressure. Once the alpha blockers set in and you control blood pressure with the alpha blockers, then you could take them to surgery. Are there any indications for any other blood pressure medication in these patients? The answer is no. It's alpha blockers, either phentolamine or phenoxybenzamine. Phentolamine is reversible, phenoxybenzamine is not. Some people like one or the other, but it has to be with one of these two alpha blockers, phenoxybenzamine or phentolamine. How much do you give? Enough to control blood pressure. Once the blood pressure is controlled, then you could think about taking the patient to the OR and remove it definitively. A couple of other things. They ask us, well, these patients are volume depleted, they're orthostatic. So you give them more antihypertensive medication, they may get hypotensive at some point. So while you're repleting while you're giving them alpha blockers to control the blood pressure, you have to replete the fluids. So they usually get a lot of fluids. Sometimes you admit them for about a day or two in the hospital, so they get a lot of fluids in the hospital. And then people have asked me, well, what if they still have palpitations despite the alpha blockers? They do, commonly. Only when you've stabilized the blood pressure, then you could add small amounts of beta blockers to control the symptoms of the palpitations. Please be careful. If you give alpha blockers from the beginning plus beta blockers, you're going to leave unopposed alpha receptors right away, and you're going to get a hypertensive crisis in this patient. So you could only use alpha blockade in the beginning, and once the blood pressure, and only when the blood pressure is stable, then and only then do you use low amounts of beta blockers to control symptoms in these patients of palpitations. That's the only reason why you're giving them beta blockers. And then, of course, you take them to surgery for definitive treatment. And that's the end of our adrenal gland session.